Today, I'll be discussing teaching surgical planes with perceptual fluency techniques. For disclosures, I did co-found a company called Edgeraffe LLC during my time in the lab. This company is designed to create educational products for surgery trainees. And some of the products we're building will be based on some of the research that we talk about today. However, I really don't do this for the money or anything like that. I really just think that it's a shame that so many interesting insights get locked away in research papers and never actually go out into practice to help the way we teach and train our surgeons. So take what I say with a grain of salt. So why should I care? Hopefully, I tried to find a way to make this topic broadly applicable to everybody who's here at this talk. And so hopefully everybody in the audience is either a surgeon in training who's really trying to become an excellent surgeon, or somebody who trains surgeon as part of their professional career and also invested in helping those surgeons become excellent. This is important because we're getting more and more data showing that surgeon skill leads to better patient outcomes across a gamut of surgeries. Just in these alone, we look at bariatric surgery, cancer surgery, Whipple surgeries, etc. And perception, or what we more colloquially refer to as seeing planes, is a critical part of surgical skill. I really like this paper published back in 2003 in the Annals of Surgery. Strikes pretty close to home given some of our recent M&Ms, talking about the causes and prevention of laparoscopic bile duct injuries. And they actually found that when compared to things like technical errors or gaps in decision-making knowledge or the use of safe techniques, that was actually misperception or a visual perceptual illusion that was the primary cause of error in basically all of these operations. So, an incredibly important topic across the entirety of surgical career. And in this talk, I'm going to make a pretty bold claim, which is that we can actually make a lot of progress in this ability of surgical perception, or the ability to see surgical planes with short, counterintuitive learning techniques. And I think anytime we see something that's counterintuitive, it can teach us something that we didn't know about how surgery is taught and learned, and maybe give us some fresh new ideas for how we can change things in the future. So my goals for this talk: first, we've done a little bit of this already, but to discuss the importance of surgical perception and expertise and how it inspired my research. I want to show you the power of perceptual fluency techniques that I studied in the lab to teach the skill of seeing planes, or what I'm also calling surgical visual perception, I should say. And then we'll also, at the end, discuss a few ways that these findings can change how we as learners learn surgery and we as teachers teach surgery starting today. So first, the inspiration for me, like probably everyone in this room, I was a very nervous medical student. I'd been exposed to surgery. I was really interested in it. I wanted to be a great surgeon, and I noticed that there were some surgeons, or also some residents, that people thought they were really good at their job. They were really technical, and I wanted to understand what made them an expert, and how could I potentially be that way some way in the future. And at first, it was pretty discouraging. We kept using these fixed terminologies to describe people who were good. We said they had great hands, or we said they could just see the planes. We think about fixed birth growth mindset with the work of Carol Dweck. Of course, a fixed trait is something that you're just born with that can't really be developed. And then a growth mindset is more about understanding that traits can be developed. And unfortunately, a lot of our terminology around surgical expertise is talked about like it's a fixed trait. And so on one hand, I was hoping that maybe I could be one of these lucky people to have great hands or good eyes. But I also had a long experience in athletics and knew the importance of practice in extremely challenging physical, technical fields and other aspects. So I suspected that this was a bit more malleable than we might otherwise suggest. And I was inspired to look into particularly the visual aspect of surgical expertise by a couple of anecdotes from my clinical career. So first, Dr. Shaw's a liver transplant surgeon at Cincinnati, one of my mentors, and I was watching a liver transplant, and one of his fellows asked him, "Oh, can I touch that back there?" It was something behind the liver. I don't remember the actual details of the case right now. And Dr. Shaw said, "Sure, you can touch it, but you don't operate with your hands, you operate with your eyes. So I don't know why you guys want to touch everything." And that really stuck with me, especially when a few weeks later on one of my sub-eyes, I was watching the PGY2 kind of struggle their way through a lap chole when they were post-call. And at one point, the attending looked over at me and she said, "Chris, it's a lot harder than it looks. Why don't you get over there and you'll understand what I mean?" And I was terrified because, one, I was being asked to operate on the spot, having never done that before, certainly not laparoscopically, and two, of course, I was like, what attitude was I putting off that she thought I needed to be, I guess, taught a lesson by operating. But anyway, so I went over and got the stupid foot pedal and the Bovie hook and looked at the gallbladder. And I had no idea what to do. All I had to do was probably take it off like 3 cell layers of peritoneum to get it off the liver bed. And I'd been watching my PGY2's hands, and I saw that the movements of the hands weren't very difficult. I knew my hands could definitely do those moves, but without the actual perception of the operative field, I didn't know where to make those technical movements. And so this really solidified for me that vision and perception was foundational, and you couldn't have good hands without good perception. And it also helps that as a med student, you do a lot more watching than doing in the operating room. So this seemed like a good place to focus initially. So I boldly went forth and decided that I would figure out everything there was to learn about how to understand or learn surgical planes. And I found basically nothing. And in retrospect, this isn't that surprising for a couple of reasons. So first, there's the expert blind spot, and which you can read this definition as well as I can read it to you. But in plain language, basically, it's very difficult to remember what it was like to be an intern. And as we get farther and farther up this hierarchy of medical expertise, a lot of what we know becomes, depending on the specific learning terminology you want to use, it's unconscious competence or it's moved into your subconscious. But it's basically something that is very hard to go back and understand. I think this is actually why the Socratic method is such a good method in medical education, because it continually centers you back on where your learner's needs are. And when you think, just thinking back to yourself, back when I was a medical student, did I understand this? Could I know this? It's very difficult to actually accurately estimate where the knowledge is of learners at different levels. And the second aspect is that perception itself is completely subconscious. So not only do we have experts that can't remember what it was like not to understand surgery, but we're also talking about seeing planes, which is this subconscious process that's almost never something that we can articulate in words. So for example, you don't think consciously about, this voice, I heard this voice and it had this specific pitch and they lilted their words this way. And I think that's such and such, right? You said, that's my spouse's voice. You don't look at this picture of my dog Ruby and have to consciously deliberate. Is this a cat? Is this a dog? Does it have, it looks like it has 4 legs, but the ears are a little bit floppy. No, you just look at it, you perceive it. It all happens below the level, or outside the level is maybe a more accurate word, of conscious processing. Of course, sometimes the perception is a little bit harder than others, but again, there's very little conscious deliberation going on. So at this point, this brings me to about my lab time. I'd spent some time working as a PGY1, PGY2, and then I still hadn't really figured out this question. And I decided to join Dr. Martina Rao's Learning Representations and Technology Lab over at the UW School of Education. She has a focus on learning with visual representations, and I figured that there would be some sort of relation in learning surgical planes. And she was thankfully willing to take me on as a student and kind of bear with my crazy practical surgery ideas that were sometimes not the most grounded in classic theoretical education. So now we've spoken a bit about the importance of perception and surgical expertise and how it sparked my research interests. And now I'm going to go a bit deeper into my actual master's work and the research I did in the lab and how the perceptual fluency techniques can be used to train surgical perception. And so my first hypothesis was, I just read about the expert blind spot and I thought, that's it. The attendings, they just don't remember what it was like to be me, to be an intern. So they don't think to teach us planes. And so if we just knew as attendings that we need to teach planes, we could just teach them to the trainees and all would be well. So my first experiment was designed to compare a couple of different teaching strategies. The first is what's called sense making. And first I should mention that this was an experiment based on inguinal hernia anatomy, as you can see on the screen. And specifically the task within the experiment was the identification of the hernia sac or the peritoneum. I'm not going to go too deep into the specific learning science behind sense making and perceptual fluency, but when you think about sense making, just think about verbal explanations. This is the type of knowledge of images where I can look at this image and then I can explain in words what's going on and relate that to other aspects of my knowledge through this verbal medium. This is basically what I thought was missing in medical education, is there were no attendings describing to me what these planes should look like and how I could recognize them. So for my intervention on the sense-making aspect, as I made this instructional video that described in words how to recognize the hernia sac. So I used words like, this is this flat white structure. It kind of looks like a sheet. It has these discrete boundaries relative to other tissue. It's white instead of red and yellow. It's got these kind of blood vessels upon it that exist, but they're not too close together, things like that. And what I made at the time was just my control group. I didn't even know it was called Perceptual Fluency at the time that I designed this experiment. But it's basically like visual flashcards where I would, I figured, what happens in real life? We just do case after case after case after case. We get exposure to anatomy over and over and over. And eventually we just kind of recognize this. This is kind of a truism in surgical training, right? So the intern can't see the planes and the senior resident can, and it's really unclear what happens in between. And so I figured that you could kind of accelerate that effect by showing people different snapshots of anatomy sequentially. So what I mean by that is, instead of in one operation, you identify the anatomy and then you kind of have that anatomic knowledge stored in your head going forward, and you don't really keep testing it throughout the case. In this case, I could take snapshots of different operations at different times and mix them together. So each individual image was a new challenge where you had to kind of figure out and sort out the surrounding anatomy and figure out your operative structure. And I figured that this would give you some reps of what happens in real life. And the big picture for this, for perceptual fluency, just think of it like a language. So just like you become fluent in perceiving a language, in this case, you're becoming fluent in perceiving visual stimuli of the operating room. So it's something that you can do without necessarily being consciously aware of it and without having to verbalize it. So I designed a randomized trial, again, learning to identify the hernia sac in operative images. So it was 42 participants, block randomized by experience level into two groups. As you can see, there were about 20 patients per group. They each got a pre-test and a post-test. These pre and post-tests were basically looking at some of these anatomic flashcards without any sort of feedback. I guess I should have said back here. So these flashcards, they would look at the flashcard, be asked to click on the hernia sac or the peritoneum. They'd click on it, and it would outline the structure and tell them if they were correct or incorrect. But the key here is there's no verbal description, no verbal feedback. All it is trial, yes or no, and then visual feedback. Trial, yes or no, visual feedback, but nothing about like verbal descriptions of things going on. So anyway, so they both got a pre-test and a post-test that was basically like a visual flashcard, but without any sort of feedback. Then one group got the sense-making video that I described before with the verbal explanations, and then both groups got perceptual fluency training with 30 images, and then they took a post-test. So much to my chagrin initially, there appeared to be no benefit from the sense-making. So you can see the two groups here, both the graphs look basically the same, from the pre-test in the blue to the post-test in the red. And while that might have disappointed my learning sciences advisor, to me as a practically minded person who all I wanted to do was really figure out, how do I learn this? How do I help us all learn to teach surgical planes better? I was actually really excited because we saw these massive increases in ability to recognize these surgical structures from around 50% beforehand up to around 80% afterwards. And then this was in pretty quick interventions that only took a few minutes. Now, before I got too excited about this, I wanted to make sure, is this something that I'm studying clinically relevant? This is a very difficult question to answer, of course, but what I ended up doing is looking at those pre-test results. So before the intervention, the participants got any sort of intervention, and I stratified them by experience level. So low experience was medical students and junior residents. Middle experience was residents in the middle of their training. And then high experience residents were PGY4s and PGY5s. And then I also had the pre-test given to a few expert surgeons who had at least 15 years of experience. And you do see this nice dose-dependent response where the more experienced you are, the better you are at recognizing these anatomic structures. And so while far from being proof, this to me felt like pretty good evidence that we were on the right track with something that actually has clinical relevance. But after that small first trial, I was left with quite a few questions. One is, it just seemed a little bit too good to be true. So, more verification is always better. I wondered a bit about sequencing effects of giving the two interventions. I wanted to do this with some harder anatomy. As you saw by the last slide, you can see that the high experience residents, they were pretty good at this anatomy already, so I was worried that there was a ceiling effect for them. I also wanted to more clearly separate out the perceptual fluency and sense-making techniques and really weigh which benefited the actual outcomes. And finally, I wanted to look into lasting learning gains. So previous perceptual fluency interventions had shown lasting learning gains out months and years. I wanted to at least get some aspect of that into my data. So I designed a second trial. This one, as you can see from this image, was focused on identifying the crus of the diaphragm during a paraesophageal hernia repair. So I was trying to make it a little bit more difficult anatomy. And as you can see here from my little flow sheet, this was another randomized trial, again, 44 participants. You can see that we had one group with the perceptual fluency training first, and the other group got the sense-making training first. Both groups underwent a pre-test, a mid-test, a post-test, and then a delayed test. All of those tests were, again, basically those perceptual fluency visual flashcard images with no feedback. And then the perceptual fluency group on the left, they got a perceptual fluency training module first, followed by the mid-test, and then they got a sense-making module. This module, I did use, instead of making a video, I did use a review of a select image of a surgical textbook. I did this to make it a little bit more kind of ecological or real world, right? Like, we're always told to study for cases. I've been studying for all my cases. I was frustrated. I felt like no matter how much I studied, it didn't actually prepare me to operate. And yet still, that's kind of the classic surgical advice. If you're not doing well in your cases, you need to prep more, you need to read more. And so I wanted to have that kind of still sense-making, but more kind of ecologically typical sense-making methodology here. Some other key differences in this test. So you can see that there's testing after each individual phase, so it can more clearly tease out the effect of each intervention. I look at this in two different sequences. And then there is a 7-day delay for a delayed test at the end. Because I wondered, maybe the benefit of sense making is not so much in the short term, but in the long term, you have this heuristic to go back to when you're a little bit rusty. Of course, 7 delays really isn't that long of a delay, but that was the goal. So again, I was trying to look at ecological validity. I looked at my low, medium, and high experience residents. You can see I certainly was able to choose harder anatomy for my experienced residents, and that there's a significant increase from low, mid to high, and then even from high to the expert surgeons in their ability to recognize this anatomy. So again, this was reassuring to me that this is something that, if not causal, is at least associated with surgical expertise. And then the results of this trial were also quite exciting for me, and it really reinforced that perceptual fluency, as opposed to any sort of sense making, is key when it comes to recognizing surgical anatomy. So you can see group M on the left. This was the perceptual fluency training first group. So you can see both groups started off about 50% accurate. And then the group here jumped from 50% to around 80% after getting perceptual fluency training. No real increase after sense making. And then the learning gains persisted on the delayed test here in kind of this teal color. And if we look at the other side, the group that got sense-making training first, they really didn't improve at all from their 50% baseline. And then they got their perceptual fluency training, jumped up again to about 80-90%. And then the delayed gains were still seen in the learning outcome. There was no obvious sequencing effect as far as the difference outcome at the end of the study either. So I also wanted to point out some other implications I saw in my data. Importantly, that there's this really large variability even within PGY levels. So I've got both experiments here. I've got data from experiment 1, the first one we talked about here on the left, experiment 2 on the right. And while it does show on each experience level that each group does have significant increases, it's not just useful for the junior residents. I also want to point out, look at how wide the variability is, even for example, like middle experienced residents. So some people are really just very much able to recognize the surgical planes even before this training happened, and others are really struggling. And you can imagine how this might put somebody in a vicious or virtuous cycle in their surgical training, right? So one resident comes to the case, they can see planes, they kind of understand what they're doing. They get to do more, right? That case, they get to do more. So they learn more that case. And the next time they come back, they're that much better prepared. They get to do even more. They learn more, right? They start to kind of take off on this accelerating curve up. Whereas somebody who starts off down here at the bottom, they're probably not going to get to do as much of that case. They get to do less. They get some less learning out of that case. The next case they come, they're even less prepared, or they haven't improved as much as somebody with more experience. And so you can get this vicious cycle of like, if you start off with some sort of benefit, whether that's from experience in the past, mentoring, etc., it can really help you take off because of this graded autonomy that we give. But if you don't have that advantage, you can be pretty hosed, and it can impact your training almost throughout your residency. And so I think training like this has a real opportunity to level the perceptual playing field for people who come in with all these vastly different experiences, and give everyone an option to start succeeding and making the most out of their operations from an early point in their training. Second implication is that this learning was incredibly efficient. So we actually directly measured the amount of time people spent on the perceptual fluency training modules in this task, and it was 3.5 minutes. So again, these massive increases in perceptual ability in a 3.5-minute intervention that can easily be fit into a busy resident workday when they're preparing for their cases. So that was kind of the crux of my research, and I want to talk about what these implications could be for perceptual fluency and perceptual training being integrated into surgical education. So first, and probably the most obvious, is that we could just take modules like this, create them for all different types of operations, and distribute them for surgical trainees to use to prepare and use to study. And that's what we're trying to do with that company that I disclosed at the beginning of all this. So we've built this platform online where people can basically take these perform these sorts of flashcard-based modules to learn surgical anatomy. So this is an example from a foregut case. The trainee looks at this image. They're supposed to identify the left triangular ligament. They click on it. It highlights it, tells them they were correct or incorrect, and then they go on to the next flashcard. Here's another example. This one, still a foregut case, asked to identify the caudate lobe. You can see they clicked on it correctly here and highlights that anatomy. If you get the answer wrong, it highlights it in red. So if somebody clicked outside, they were trying to identify the esophagus. Again, still another, what looks like a paraesophageal hernia repair, aorta back here, cruce right here. But again, it's not telling them any of this. It's just telling them yes, no, highlighting the key structure. And my goal for this long term is to have this be like a really useful crowdsourced repository of surgical expertise. So we're all very familiar with the SCORE curriculum, where basically residents like myself, I think a lot of my co-residents have done this too. Their faculty member says, hey, we're going to do this SCORE module. I got asked to do the SCORE module on X, Y, or Z. And we kind of use our expertise to create this kind of encapsulated module. And then we send it in to the centralized resource that's in charge of curriculum design, etc. But the actual content itself, the learning content, is created by the community and then collected in the center. And so this could be the same sort of thing. So a surgeon might have, in this case, uploaded a video or snapshots of, it looks like probably a gastric sleeve in this repair. And you can see that it has this very straightforward interface where the surgeon can then select a certain anatomic structure. In this case, they're labeling the stomach, and then they just start to outline the stomach here. And then you're able to develop these data banks of labeled operative images with various structures in them that can be used for people to train on. And again, I think we have precedent for this in how we run the SCORE curriculum, and that this could be a really useful and wide-ranging educational resource, not just for general surgery, but really any surgical or procedural field that in which complex perception is important. And again, I think this is important for many reasons that might not all be intuitive. So first of all, like we talked about before, I really think this sort of thing can level the perceptual playing field for people who have very different opportunities as medical students. It's an unbiased way of training. And I also just really think that even if you get the best training, like it's almost impossible to get the best training throughout the incredibly broad field of general surgery. So you might have had a great, junior experience or PGY3 experience in a certain field, but had barely an experience in another, right? Here, an example might be cardiothoracic. So a lot of us aren't great at our thoracic anatomy, but the opportunity to train with visual flashcards like this, or with perceptual fluency, if you're going into a field like that, you could really enhance your own training. And that's what I'm talking about when I say that this gives the opportunity for deliberate practice or shaping your own experience. So instead of being tethered to what rotations you get to do, how much operating you get to do on those rotations, whether that's with the amount of residents on or faculty taking vacations, things like that. Like our experience is actually quite variable. And until this point, we don't have really much that we can do about this. And certainly no one would argue that you can just, train your vision and become an excellent surgeon, but at least this gives you the opportunity to do some degree of personal development in a field that you've shown interest to and maybe hope to have some expertise in the future. Then the final issue that it partially addresses is this idea of preserving surgical expertise. And this has struck me pretty hard when I matched here for a transplant fellowship and then had Dr. D'Alessandro immediately retire. But it has struck me throughout my kind of short surgical career that we get these kind of giants in the field, and each institution has these surgeons that are just, these really incredible experts. And, people are so lucky to be able to come here and train under the surgeon. And then one day that surgeon retires, and then no one else, all that knowledge just goes with them. Of course, there's some degree of carryover from getting to train with people they've trained, etc. But I can't help but wonder if there's something lost in being unable to actually work with that specific person. And something like this could be a way of preserving at least some small sliver of that surgical expertise. So even if you didn't have the opportunity to train to that person, whether from temporal constraints because you just didn't train at the right time, or even maybe you matched somewhere else, but that person, the way they see the field would have really resonated with you. It just gives an opportunity for us to begin to broadly disseminate this really important surgical knowledge and have a bigger impact as educators. And then finally, I think this is an opportunity for career-long learning, or CME. I'm going to talk a little bit more about why I think that's the case. First and foremost, as I'm coming up quickly towards the end of my residency, I've realized that graduating from residency is hardly the pinnacle or of your surgical expertise. And certainly as I go into fellowship and practice, there is much, much more learning to be done. But I also want to point out that there's this classic dichotomy of expertise when we think about there's perception and then there's thinking. And historically, most of us and most of thought on this topic has said that, what really happens is the eyes are like these little cameras, right? Like nothing changes. I just perceive the same thing over and over, but it's what I think about and how I, consciously deliberate and process this information that really changes as I become an expert at something. And if you think back to what we talked about at the beginning, this might be an oversight, especially when you consider that this is the only way we can talk to each other about expertise. But that doesn't necessarily mean that other aspects of expertise aren't equally valid. So we have this dilemma of which is it? Does perception roughly stay the same and cognition really improves, or is there a corresponding increase in both? And some of the first research to look into this topic was actually done by de Groot and then Chase and Simon back in, I believe, the 1960s, 1970s, and they looked at chess players of all things. And it was really interesting. They did this study where they looked at chess grandmasters and then they compared them to other chess masters. So this has classically been misconstrued as kind of an experts versus novices study, but this is really probably more accurately a study of chess super experts against just chess normal experts. And they wanted to look and see, like, okay, chess is a very cognitive game, right? Like what cognitively changes to delineate chess super experts from just normal chess experts. And they looked at things like how did they search for moves? How deep did they search for moves? How much time did they spend searching for moves? They didn't find any differences in any of these tasks, but they did do a perceptual task, and they found that the chess super experts perceived the boards faster and more effectively than just normal chess experts. And so this, in my mind, provided really strong evidence that even at the highest levels of something as perceptually bland as a chessboard, right? Like you look at a chessboard, all you really need is pieces and locations, right? You don't need to know, like, how does this chess piece align up next to the other one? And is that a plane or isn't it, right? It's just a chessboard. And yet still, at the highest levels of chess, perception actually made, or seems to have made, a really important difference. This study's since been replicated and is kind of a well-known aspect of learning sciences literature. And so in my mind, this provides some pretty good evidence that expertise is not just cognitive, but that there's a large perceptual component as well. And going back to the beginning, if we know that surgeon skill and surgeon expertise leads to better outcomes, this may well be in large part related to the perception that these surgical experts have developed over time. So that said, these are all kind of everything that I've talked about so far for implications is kind of this pie in the sky, what could happen in the future. And a lot of us want to know, well, I'm learning surgery now, I'm teaching surgery now. What can I do today based on this understanding of how important kind of this unconscious perception and perceptual fluency is? And so to start, I want to talk about some strategies that, as a learner of surgery, you can use to help use these findings to guide your understanding and learning. So first, I want to talk about case prep and studying for cases. And so, the classic dogma that we use or hear in surgery is we say, read more. What should I do? Read more. Like, your knowledge is fine, but you still need to read more, etc. And I think we should replace read more, not completely, but at least partially, with watch more. We are in an era of YouTube where there's all sorts of surgeries put on YouTube. And I feel like we've historically had a bit of a aversion to this because we say, that's not regulated. Like, those surgeons might not be doing it, quote, right. Like, especially people who are willing to put their stuff up on the internet. Maybe that's from a different place. We don't trust them as much. And I want to say, first of all, that a lot of that's not true. There's some excellent surgical videos out there on YouTube. But even if it was true, you can certainly, and I would argue that you should certainly use video resources of surgery to just get used to seeing the planes, to perceiving the anatomy. So, for example, instead of maybe trying to watch a case straight through and memorize exactly how it's done, I would argue, who cares? The surgeon almost certainly does the case differently than your attendings do anyway. Just find a video that looks of reasonable quality and then start watching it, and watch it till you can identify the anatomy around you. And once you can identify the anatomy, skip ahead a few minutes, try to identify the anatomy again, skip ahead a few minutes again. Keep doing that until you can consistently, over different types of videos, start to get a sense of what's going on in the case, where you are anatomically. And you'll be basically doing this for yourself. And one, it's something that doesn't rely on having a video that is the exact technique that your surgeon's going to use. And two, it's a much more time efficient way. You don't have to sit down and watch a 45 or 3-hour video of a surgery, but you can, get these quick little snapshots of anatomy and start training your perceptual abilities, in addition to studying, kind of reading more and studying cognitively to prepare for these cases. The second really important opportunity that I think is sometimes lost or underappreciated is double scrubbing. And so this is a perfect opportunity to work perception. A lot of people have this sense of, I don't want to do that. It's beneath me. I'm a resident now. I shouldn't just be watching a case like a medical student, etc. But even if you're not doing anything, there's very little cognitive load on you right now. All you're doing is watching the case, picking up the ability to, one, just see what's going on, but two, to really enhance your perceptual abilities by watching this case. Again, and there's also many other benefits to double scrubbing. I'd say mostly psychologically, right? You get used to the OR staff gets to know you, the surgeons get to know you, you start to develop a relationship. When you do come into their cases to operate, you have some experience, and they just know that you're invested and interested in what they do. And so I know every attending I've ever talked to loves to have somebody else come in and be involved in their cases and show interest. So it's something that worked out for me really well in the past. I got a lot out of it. I'd encourage you to try it yourself in training. And then finally, what you really got to do is trust the process. I'm going to talk a little bit about this graph in a moment. But what I mean by this is, like we talked about, perception is subconscious. And so what happens a lot of the time is you just struggle. And then one day you can see this plane and you don't really know what happened. You kind of wonder, like, were all those cases I saw as an intern just really complex planes? Now the planes are clear now. But what's really happening is this subconscious processing and improvement is taking place, and you don't really feel that. So, no matter what, surgical training works, and you will, just with time, just with exposure, improve your perceptual fluency over time. And so a little bit about this graph. I love this graph. This came from a paper by Kelvin and Garrigan in 2009 on perceptual learning and human expertise, but the graph itself is actually from a paper published in 1899. And so pre-1900s research meant drawing your own graphs, labeling your own axes, drawing out your own lines. Like, we should all be very appreciative of our statistical software today. But what this graph does is it does show this really interesting aspect of what we call discovery and fluency effects. And so at first, you're just learning what's going on, right? You're kind of getting a sense of this underlying base structure. But if there's a superstructure, your body will slowly, once you've mastered the base structure, start to master these larger invariant structures. And that's really what's happening as your perception grows. And so it's a little bit abstract. So to put it very concretely, this study was of telegraph, or people learning to interpret telegrams back in the 1890s. And these three lines, the line on the bottom is the line that was just trained on random letters. So they were able to gained some fluency in reading these letters, but there weren't any big jumps in improvement after that. The second group was letters grouped into words. And so they had the bigger improvements while they memorized and learned how to perceive letters. But then you see there was also a big jump later in the curve as they realized their body was able to start perceiving words as themselves, these larger invariant structures. And then the last group was getting actual messages. So they showed, again, a much larger increase overall, but it's because they were, again, first they were learning the letters, and then they had this ability to put those letters and start perceiving words. And then they were able to not just perceive words, but start to understand complete message structure. And then their telegram interpretation really took off relative to the groups that didn't have those underlying structures to start to perceive. And so you might make the analogy to surgery where initially you have no idea what's going on. Then you start to be able to see these planes. As you start to be able to see these base structures, then all of a sudden, all these bigger invariant structures start to fall into place. And then what about for those who are teachers of surgery instead of just learners of surgery? So attendings, chief residents, anybody trying to help somebody else understand what's going on in the operating room. And I think the first and the most important point is to always remember your own expert blind spot. So it's really, really hard to put yourselves back in those intern shoes or those medical student shoes and remember what you didn't know. And of course, remember that those medical students and interns, they feel like they are rewarded for knowing more, right? And so they're always going to do their best to do I see what I think I'm seeing? You might ask, oh, do you see that up there? And we always say yes, right? Like there's a strong implicit bias to say yes, because if you don't, then you think you're going to get the case taken away. And so you think you're seeing something, but how can you know you're seeing the same thing as somebody else? It's very difficult. And so you should always, just like in the Socratic method, always assume that your learners know very little and start really working from the base up if you're identifying structures in the case. Don't just say, oh, you see that, right? And assume that you guys actually are interpreting that same structure as the same thing. So have some patience with your learners and really start off by really communicating very clearly about even the most basic of perceptual cues you're picking up on. And then secondly, you guys also trust the process. And so, I have, many, many funny stories from my training where I have distinct memories of Dr. Lay saying, Chris, stay on the bottom of the gallbladder about 100 times while I was doing a chole with him and going a little bit too high, a little bit too low, or Dr. Abbott saying, go up, go down, go up, go down. And, it feels like the trainee is just, they're adjusting, they're continually adjusting, but they're just not getting it. And all those little steps are very important. And again, part of this subconscious perceptual expertise that's being developed, even though it might not look like it to you as the teacher or feel like it to you as the learner. Those are very important aspects of the learning process. So if you just stick with it, keep doing it, you are doing something valuable for your trainee. Another thing you can do, and this is a little bit even above and beyond, is that you can either pick or make a perceptual resource for your common cases. Again, as much as I can tell somebody as an intern or a junior resident that they should go watch videos to help prepare for the cases. If they have a resource that's really endorsed by the faculty, I think they'll be much more likely to start to train their perception outside of the operating room instead of just doing the classic reading that we always do. And they might be a little bit worse at some of the esoteric PIM questions they get about what happened in Egypt the very first time this disease was ever recorded on a hieroglyph. But I would argue they'll be more prepared for the actual task of operating. And this is a good point to talk briefly about the video library that I've created at our institution. So you can see in this case that this is a video Dr. Guerin made of his gastric bypass. And he's making the point here about how specifically lining up your JJ anastomosis at the anterior mesenteric side helps prevent a JJ stricture, a point that's very difficult to make and understand when you're just drawing it on the back of a patient list, but very useful and easily understood in terms of a video. So again, these video resources, in addition, right? So these are almost two different things, like on one side, there's the importance of just perceiving the surgery as it's being done. So a perceptual resource like this is going to help your trainees train their perceptual expertise. But there's also a lot of cognitive details that you may not remember or may not have time to really go through in the OR that you can add into these videos, and your trainees come in much more prepared. And everybody that's made these videos with me has said, I do notice a difference. The trainees come in, they really do know a lot more about what's going on than they used to. I also want to point out, you can see here that this video has got like over 300 views, right? It's been up for 3 to 4 years at this point, and there's certainly not 300 residents, right? So people are coming back and using these resources over and over because they are just that valuable. I like to say, if Dr. Guerin can do it, we all can. So if you're interested in making resources like this and putting them onto the UW video library for our resident trainees, just contact me and set you up. And then finally, even if you can't make your own, you could at least contribute to future perceptual fluency-based resources. So we need everybody to get in on this in the future, whether it's providing the content of the surgeries themselves or just providing the expertise of interpreting the surgical footage. My true vision for the future and hope is that someday we will all be creating and maintaining resources about how we perceive the operative field. All right, so in conclusion, hopefully I've convinced you guys that surgical perception is a critical part of surgical skill, that perceptual fluency techniques can rapidly teach junior trainees surgical anatomy and surgical planes. We talked about a few ways that the use of perceptual fluency training within the current model can address shortcomings of the system. And then finally, we finished with a few points about how understanding this idea of perceptual fluency can change how we teach and learn surgery today. And with that, I'm happy to take any questions. I did put this QR code up. If anybody is particularly interested in perceptual fluency and the development of resources, we need everybody to get involved, whether that's the most junior medical student or resident who can give feedback and test these sorts of resources to see if they are actually useful, up to very advanced surgeons who would be more providing their expertise in creating them. If you're interested, you can scan this QR code, leave your email address, or just reach out to me. And these are the resources.